Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Shionogi. It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
Hello, everyone, and welcome to this program, Keeping Current with COVID-19 Prevention, Expert Insights on Post-Exposure Prophylaxis. My name is Dr. Wendy Wright. I am an adult and family nurse practitioner and the owner of a nurse practitioner-owned and operated primary care clinic, and I'm located in Amherst, New Hampshire. It's truly my honor today to serve as the chair of this meeting and to be standing alongside my esteemed colleagues. I'm going to now turn it over to Dr. Vega to introduce himself, and then we'll turn to you, Dr. Wall.
Thanks for kicking us off, Dr. Wright. Really great to be here. I'm Chuck Vega. I'm a clinical professor of family medicine at the University of California, Irvine, and I'm also an assistant dean in the medical school here. I've practiced only in the biggest safety net clinic here in Orange County in Santa Ana, California. And with that, Dr. Wall, please take it away.
Thank you, Dr. Big and Dr. Wright. I'm David Wall. I'm an infectious disease specialist at the University of North Carolina in Chapel Hill and run our HIV clinical trials unit that also did a lot of COVID-19 research at the time and also see patients in clinic. So thank you.
Thank you so much to both of you. Let's kick this off with an introduction to this program. So over the course of the next 45 or so minutes, what we want to accomplish is we want to discuss COVID-19 and key evidence for preventive care options. We want to discuss strategies for mitigating COVID-19 related complications, particularly in our high-risk populations. And we're going to test your skills at the end with some case studies. And last, we want to discuss collaborating with that interprofessional team to mitigate COVID-19 related complications. So let's kick this off by talking a little bit about the evolving landscape of COVID-19. And what you're seeing are some of the pictures that we all took during COVID-19. And for me, these pictures represent a really tough time, as it did for many of us. You can see myself and my colleague where we stood outside winter. I'm in New Hampshire, middle of the winter. We were in a tent taking care of patients. I'm in primary care, like so many of you are. And primary care was really the lifeline for patients who were scared, who couldn't go to an emergency room, or who were ill and facing COVID-19. We did more than 2,500 to 3,000 visits in that tent outside. Dr. Vega?
Yeah, that's amazing. And right, it was a traumatic time for so many people, and especially in communities like Santa Ana, which were disproportionately affected, both in terms of rates of infection and mortality. But it's just amazing how it's different now, and it's changed so rapidly from a period of intensive fear and then elation that we had a vaccine, and now we have treatments that are available too. And now it's really hard to get folks vaccinated, honestly, and they're not necessarily thinking about COVID-19 and its complications yet. It's still out there. And it surges every winter, it surges every summer. And I have a lot of patients who are at risk. It's just a different way of thinking about it. And sometimes I don't want to traumatize people, but going back to how they felt in 2020 may not be a bad thing, just so they can, if it can make them active in preventing disease.
Thank you. Dr. Wall?
Yeah, and I think our point is that, we're three people who were very much involved in responding to COVID-19 as it first came along in 2020. And I set up a drive-through mass testing facility outside of our hospital to protect our hospital, sort of protect the perimeter, and then moved on to mass vaccination sites and making those happen, and then even a monoclonal antibody clinic so that we can protect more people. So all of us have had experience dealing with this from the very, very beginning, rather than from an armchair perspective, but from frontline perspective. So that's what I think you're going to hear a lot of today, especially as so many people, as Chuck said, try to think about this in the rearview mirror or see this in the rearview mirror. I think it's good to look both in the rearview mirror and forward when you're driving.
Thank you so much. So let's talk a little bit about some statistics. And if we look from October 2025 through June of 2026, you can see the number of illnesses related to COVID-19. You see outpatient visits, and certainly there's a big, it's 4 million to 12 million. There's a big variation there. A lot of that has to do with the fact that so many people aren't getting tested now and they don't even want to be tested. There was a day, as many of you remember, we had to report all these cases. And so it was a little bit easier to keep track of how many people were affected by this virus. But at the end of the day, COVID is not gone. And you see here that in this span of time, which is about 8 or so months, there was somewhere between 13 to 41,000 deaths and about 120 to 240,000 hospitalizations. Those are statistics that are certainly much easier to track. So you've heard our panel here say it was a tough time. And if you look at the mortality due to COVID-19, and we go back to 2020, look at those spikes in 2021. Certainly, those spikes are not nearly as high as they were back then. Probably a lot of that owing to the fact that many people have been vaccinated, many people have antibodies, and certainly the Omicron and its subvariants may not be nearly as severe as some of its earlier predecessors. But at the end of the day, COVID continues to be here, despite the fact that many people want to think that it is gone. When you look at the recent burden of deaths related to COVID and you look at the week ending June 2026, you can see that about 0.1% of all deaths in the United States in those timeframes were related to COVID. Or to put it differently, about 1 out of every 100 of all US deaths in early 2026 were still the result of COVID 19. So, one of the things you heard Chuck mention, and I think this is a really important takeaway, is that one of the things that COVID has not done is gotten on that kind of seasonal pattern that we typically see with flu, where there's generally one spike in the middle of the winter. One of the things that we see with COVID is that there's always a summer spike. You've got a lot of weddings, you've got people who are traveling, and then you see that spike in the winter as well. We're often able to see those spikes also reflected in wastewater. And this is a really great way of monitoring and looking at surges and levels of COVID 19 in the community as it is measured in the wastewater. So now I'm going to turn this over to you, Dr. Vega, and ask you to bring in some multimodal strategies for risk reduction.
Yeah, because we have them, right? And this is going to be review for a lot of folks, but feel free to jump in, guys, if you want to make comments because there is some new information when we talk about pre-exposure prophylaxis, before the exposure occurs, post-exposure prophylaxis. Definitely have something new in that area, and then for intervention and treatment, not quite as much. But what we have for folks who unfortunately have severe COVID-19 or are hospitalized tends to work okay. For the outpatient, it works okay too. But there's good news regarding the vaccinations. There was a fairly recent study that was done looking at different urgent care sites, emergency sites that see a lot of COVID-19. And they found that the vaccination efficacy rate was still 50-60% against infection with COVID-19, confirmed infection, and similar numbers when it came to prevention of hospitalization. So still a fairly effective vaccine. Those numbers, just to put in comparison, are better than what we might expect, say, for the influenza vaccine, which we all recommend as well. We don't really recommend one vaccine versus the other. Really, it's just getting any vaccine on board. And of course, the higher your risk, the more you're going to benefit from the vaccine. One argument that I make for vaccines is that they have been well demonstrated to prevent long COVID. That's still a concern. It's about 3% of Americans have long COVID, have persistent symptoms after COVID, those post-acute sequelae of COVID or PASC. So that's one of the points I make with vaccines. And then my last point I would just mention with vaccines is that any severe infection can make standing disease worse. So that might be your diabetes, but it could be a heart attack or a stroke. If you've already had a cardiovascular event, having a severe infection, whether it's RSV, SARS-CoV-2, influenza, or sepsis, all of them can promote a higher risk of cardiovascular events. I found that those can be motivating for patients. But in terms of really who we prioritize for kids, you can give the vaccine down to age 6 months. So I would encourage it for all children who are 6 months and older. But of course, if you have any chronic illness that significantly affects any major organ, this is the way I like to think about it, whether it's your brain, your heart, your lung, your liver, your kidneys. If you have significant dysfunction of that organ over time, you are at higher risk. If you have obesity, you're at higher risk. So this is a lot of individuals, including children, who could be at risk, and that's why AAP, makes a special call out for them. The AAFP has a broad recommendation. As being a family physician, we treat everybody, so they recommend for children, for adults, and for pregnant women. And so you can see their recommendations here. Broadly, I think everybody who's 6 months and over should be getting the vaccine. But it is safe in pregnancy. We know that when a woman who is pregnant becomes infected with COVID-19, higher risk for preterm delivery, higher risk for pneumonia for the mother as well during pregnancy is a higher risk condition. So you have risk for the mother, risk for the baby. Better to get vaccinated and protect both during and of course, again, the more complications you have, if you had, say, gestational diabetes, your risk goes up even further. And so we really want to protect at every life stage. And then, of course, what I mostly see in my practice is older adults, and so that is real priority. And they're the group that has the best rates of vaccination. So these are really strong priority groups. And then just listening with empathy and trying to get the vaccine on board is critical. And ACOG is behind this as well. Really, they say vaccinate when you can against COVID-19. CDC also has guidelines there involving shared decision making. That's something we do, but I always try to do shared decision making where I want to make a positive recommendation. So I will talk about how I got the vaccine and I'm going on my 8th dose now, I believe. But my parents got it, my kids get it, and so I personalize it as a way to try to show that it's safe and it's very effective at what it does. And so this is kind of going back into our PrEP, PEP, and interventions after illness onset again. So we'll get to PEP in a minute, but I think we're still going to focus on PrEP shortly because we do have an option. Yeah, so that's pemivibart. This is the one that's currently available. So this is pre-exposure prophylaxis. Before anyone gets sick, they can take 2 doses IV 90 days apart. There was an emergency use authorization in 2024 for pemivibart. So this is an antibody. It was approved for at least for the emergency use based on a study done in 2024 against the dominant circulating variant of Omicron at that time. And really what they showed was immunologic data that giving pemivibart was associated with a good immune response, so that it could act at a level that previous monoclonal antibodies had acted against SARS-CoV-2. Now, it's really indicated, though, for folks with significant immune compromise. So this isn't just for, say, somebody with diabetes or obesity. We are talking about folks with organ transplantation who are getting active treatment for cancer, particularly if they have hematologic cancers, or they have other either acquired or congenital significant immunocompromised states. But if we can look at the data for a second, this immune bridging study showed that the drug should be effective. And I would also call out that in this same study, they did have a placebo group this as a secondary outcome, and they did show that it did seem to be effective to the tune of about a 70% reduction in COVID-19 infections in the pemivibart versus the control groups. And remember that if you have significant immune compromise, we want to vaccinate. That's our first line, but we can't expect the vaccine, even with a booster dose, it's still not going to improve that immunity to the same degree. The vaccine just doesn't work as well in severe immunocompromise like a lot of vaccines. So pemivibart could be a consideration, but I don't think it's really something we're going to use a lot in primary care. One reason The main thing to be concerned about is has a rate of systemic reactions along the lines of like 9-10%, with about a 1% risk of anaphylaxis. So really want to give it an infusion center where they can manage those complications if they do occur. And this is just a guide to the patients you might see in terms of the degree of immunocompromise. Really, it's in if they're in that lower risk, that wouldn't make it, but if they're in the moderate or certainly the higher risk folks, Pemivibart could be a consideration. And I think that's probably something you're going to consult with. Oftentimes, they'll already be seeing an ID specialist or an immunologist because of that severe immunocompromise.
Thank you so much. So now I want to transition over. You've heard a lot about the vaccines that are available. You've heard about PrEP. Now let's talk about identifying those high risk populations and the unmet needs that continue to exist. So you've heard us talk a lot about there is a group of people that we know based on science are at a greater risk for more severe disease, whether that be hospitalization or that be, unfortunately, death. One of the things we've learned, and we learned this very early on in the COVID pandemic, that age is a big factor, that people 65 years of age and older, or those who are frail or living in congregate living, we saw a lot of this where COVID-19 early in the pandemic really decimated a lot of these facilities. So age remains a significant risk for severe disease. But you heard Dr. Vega also talk about pregnancy or recent pregnancy, those underlying health conditions such as diabetes or chronic kidney disease, the hematologic and other malignancies, as well as those individuals who are immunodeficient or on meds that are immunosuppressing. But there's a range of risk factors, right? So someone who may be 65 may not be as much at risk for severe disease as someone who, for instance, is 85. But in the world of infectious disease, we often talk about risk stacking, in that when you're 85, you're often not just 85, you often have other comorbidities as well. So you can see that people with prior infections versus those with no infections, the range varies. People with underlying organ disease or three or more organ dysfunctions really increase that risk. So there's a wide range, even among the risk factors that we know continue to put people at risk. One of the things I always say to my patients is we can have the best vaccines in the world, but if we can't get them into your arm, they're not going to do us any good. And truly, the best way to prevent what we used to call long COVID, now called post acute sequelae of COVID, is to not get COVID. And so the risk factors for mortality and ICU admissions are listed here on the slide in terms of risk factors for long COVID. And you can see being unvaccinated or having comorbidities certainly increases the risk for long COVID as well. So, how do we get these vaccinations into the arms and how do we counsel these people at risk? Well, one of the things that's really panned out in the literature is the language that you and I use as their healthcare professional really does make a difference as to whether people take a vaccine or not, or even take screening tests, for instance. So, providing that strong presumptive recommendation, and that looks different depending upon your comfort level with the patient. But for me, it often goes something like this. I'm looking in your record today. I can see that you haven't had the COVID vaccine. We've got it available in the clinic, and I do recommend it for you. Can we get it on board today? That's what a strong presumptive recommendation looks like. Versus something that we call participatory, which is, do you want to get a shot today? Do you want to get your COVID vaccine? We know that that strong recommendation really pushes people who are in that movable middle to move over and actually step up and get that vaccination. It's also really helpful to personalize the message. If you identify a risk factor, severe obesity, diabetes, uh, advanced age, personalize the message. I think it's important for you to get your vaccine today because this puts you at an increased risk, not only for hospitalization and death, but also for long COVID as well. So personalizing the message can be really helpful. but you're not going to have everyone that's going to want to take it. And one of the things I often say is, what's standing between you and getting this vaccine today? Because if I understand their hesitancy, maybe that's something that I can address. And even if they don't take it today, I have people who come in and say, you know what? I've heard you. I now want to vaccinate my kids, or I want to vaccinate myself. And so I'm empathetic, and I will say to them, I understand it's a hard decision, and I understand that you're being bombarded by a lot of information, but here's what I have done to make sure that I have the latest information so that I can give that to you. Because an ounce of prevention is worth a pound of cure, and we know that. So, Dr. Vega, I want to turn this over to you because I know during our meetings, this was something that you felt really strongly about and have such a good way of presenting the slides. So, I'm going to ask you to jump in on this one.
One thing that comes up a lot too is like, I don't think I gave the vaccine today. Last time I felt a little sick and I want to be ready for work tomorrow. I've got my kids are in a play tonight or something like that. And if so, I'd bring up the fact that, well, with a little acetaminophen or ibuprofen, probably you'd be feeling a lot better, and it's temporary. I doubt it will last more than 24 hours. But if you do get COVID-19, we know that half of folks have to take time off work. And it's significantly disabling for at least several days. And then you also have to be concerned about who's at home, which is something we're going to get into very shortly. So that's another thing I bring up. And then I'm in family medicine. There's 10% of folks who will absolutely never get that vaccine, and even with listening with empathy and asking about where their perspectives are, they're just like, no, absolutely not. I know that it's going to be bad for me. That's a great time to pivot. You respect it. I respect that decision. Okay. Is it okay if we talk about your smoking? I have had folks who refused a vaccine actually stop smoking, which in the aggregate, like, I think that's a bigger win. So yeah, it's a great time to ask. There's always something else we can do with prevention and health maintenance. So it's a good time to bring up something that you might have on your agenda. You're going to get a more receptive audience because you respected their opinion on the vaccine. And I would just also mention that post-exposure prophylaxis, which we're going to go into right now, is not a substitute for avoiding a vaccine, but it can be helpful. And we know it's really underused. We've had it available for influenza for years, but the rates of using it are really low. So for folks at higher risk, I really want to prioritize post-exposure prophylaxis. So now we have an option in treating SARS-CoV-2 household contacts within central ear, which we're going to get into right now.
I think that's such a great segue. And before we turn it over to you, Dr. Wall, I'm wondering if there are any other comments from this first half of our program that anyone wants to chime in about before we turn it over to you to talk about the newest option available for patients.
Yeah, no, thank you. This has been a really fantastic overview of where we're at. And I know the situation has changed over time. And I think being realistic, I think folks all recognize that community immunity has improved. So the risk of ending up in a hospital on oxygen or high flow or an ECMO is much, much lower in general from most people in the United States that we see, but not for everyone, but it is much lower. So that's great. So really, I think what Dr. Wright, when you talked about avoiding long COVID, and Dr. Begum mentioned this as well, and the complications, that to me is becoming more and more of a predominant reason for people not to catch COVID, not to get sick. So that, for me, the balance is starting to tip. I'm not really so much worried you're going to end up on a ventilator, but I am worried you're going to end up on disability. And so this is something that's very real. It is double-digit % of people who do get COVID, even nowadays. And the more episodes of COVID you get, maybe the risk is higher. And vaccination can prevent and even attenuate long COVID. So that, I think, is a really important point that you guys mentioned, I think, emphasizing.
I love that. Thank you so much. So now we're going to turn it over to you to bring this material to the front for us.
Yeah, wonderful. Thank you. Well, I think this has been really helpful, and we've seen the biomedical leaps that allowed us to emerge, I think, from the worst days of the COVID-19 pandemic to now. And so we're going to talk about the further evolution of the advances that we've had seen previously and talk about novel therapeutics in different situations. And we've already highlighted that a little bit. We've talked about PrEP, and again, right now, PrEP is pretty limited to the most at-risk people. It's not very commonly used. I think the monoclonal is probably something a little bit new to a lot of people. But we're going to focus a little bit more on PEP. That's post-exposure prophylaxis. So people know this from the HIV world. Taking medicine to prevent yourself from getting HIV infected is different than what you do after a needle stick, for instance. But I think focusing now, centering on PEP is apropos to where we are today. So there have been studies before looking at, what we can do for post-exposure prophylaxis. And as Dr. Vega mentioned, we do this for other respiratory viruses, namely, of course, influenza, where people do commonly pick up a prescription for oseltamivir or baloxavir after somebody in their household or someone they've been close to is diagnosed with influenza and they don't want to get sick. And not only that, but we know that maybe, this can help prevent people from getting sick, but also if they do get sick, maybe shave off some of their symptoms. So there's a rationale here for using post-exposure prophylaxis that's been borne out by studies in other disease states. Here in COVID, we've had sort of more misses than hits. And part of that could be the complicated situation of evolving variants. So something like a monoclonal antibody cocktail, as you see on the top at CASI-MB, that would work for a while, but it's not going to work forever if we have variants that don't respond or don't match the antibodies that have been created for post-exposure prophylaxis. More recently, of course, we've looked at nirmatrelvir, ritonavir, and molnupiravir, and we'll talk much more focused on ensitrelvir. And these are antivirals, direct-acting antivirals. And in this case, again, for nirmatrelvir and for molnupiravir, we really haven't seen fantastic evidence that this works. And partly that could be a little bit about how the studies were done and their designs, and I'll talk about that in a second. And you can see here, just looking at the risk ratio, where we see more positive results. So again, going back to really the workhorse antiviral that we have now for SARS-CoV-2, nirmatrelvir with ritonavir, which we use for treatment. A study did look at this, and this was published, as you can see here in the New England Journal, as post-exposure prophylaxis, and in a design that made a lot of sense. But there was a lot of leeway here for when you can start the drug, and up to 96 hours after somebody who was diagnosed with COVID-19, you had contact with. And it looked at 5 or 10 days of the drug versus placebo. And it turned out it didn't really make a huge difference. Now, 70% of the folks in this study were from the United States. And overall, there was fairly low number of people who were exposed who were diagnosed with COVID-19. So that attenuates your power to really look for differences. So it suffered a little bit from that. And also probably that a lot of people started the drug too late. Or it's just that it didn't work. So it's unclear. So it's a little bit of a muddied picture. More recently, like really recently at the time that we're talking now, ensitrelvir has been approved in May 29th, 2026 by the FDA for post-exposure prophylaxis. This is an antiviral that you can tell by the name it has some similarity, right, to nirmatrelvir. It is approved in Japan for treatment and post-exposure prophylaxis, but is only approved here for post-exposure prophylaxis. It is a protease inhibitor. And again, this is something that we would use after an exposure, not to treat here in the United States under the indication. And this indication reflects the clinical trial data that I'll share with you in a second, and that is for adolescents and adults. That means people 12 years of age or older. And this is for people who've had contact with someone who has COVID-19. So the study that justified this FDA approval is called Scorpio PEP. And this was a phase 3 randomized controlled trial that I'll walk you through really quickly, in which important to understand some of the jargon and the definitions here. We're going to talk about index patients. So these are people who are not in the study. These are people who were in a household who were diagnosed with COVID-19. They live with other people. diagnosed with COVID-19. Their household members were eligible to be participants. So we have index patients, and then we have household contacts, HHCs, and these were people who were enrolled in the trial, and they were people who tested negative on a local SARS-CoV-2 test. At the same time, another sample was sent to a central lab for PCR testing, and we'll talk about that in a second. But these are people ideally who do not have SARS-CoV-2, who were exposed to someone in their household who did. And they had to start either ensitrelivir or placebo within 72 hours of the onset of symptoms of that index patient. Okay, so that's a lot right there. Okay, then after they enrolled in the study, they started the drug, and the drug is given at a dose of 375 milligrams on day 1 and then 125 milligrams on day 2 through 5. And then people have samples of their nasopharyngeal space on days 1, 3, 6, 10, 15, 21, and 28. And that's what we're looking at. And the primary outcome is, what happened by day 10. And I think that's very reasonable. So we talked about that there's index patients, there's household contacts that are the people who are in the study, and we talked about the design. The analysis, and I think this makes some sense, looked at people in a couple of different ways. So first, they looked at the modified intent to treat population. So these are the people who everything worked out pretty well, exactly what you would like. This is the purified population of people who are randomized. These are household contacts who the central laboratory lab showed that they did not have SARS-CoV-2. So not only did the local laboratory or the local test say that you don't have COVID, the central laboratory very sensitive PCR test of the brain tickler swab also showed that people did not have SARS-CoV-2. So that's a pure sample that we could look at, not mixed with people who might have snuck in who had SARS-CoV-2. That's the intent to treat population. Now, you can argue the intent to treat population is exactly what we want to look at because that's who we might see in clinic. We don't have maybe the PCR test. We would have a local test. So it's good to look at both of them. And again, the primary outcome was looking by day 10, what proportion of people who are the household contacts of someone who has SARS-CoV-2 dripping with the virus and couldn't affect other people, how many of them at day 10 were positive for SARS-CoV-2 on subsequent testing. Now, here's the patient population. That's always important to look at. So first of all, at the top, you can see this is a pretty large study, over 2,000 people, over 1,000 in each of the study arms, middle age. You can see the display here. Some people, maybe about, 10% were over 64 years of age. Half were female. Body mass index was around 26. That's because, as you can see on the right, this study was done not only in the United States, where about 70% of people were, but also, especially in Asia and Japan, where a quarter of the participants were enrolled, but also a little bit in Africa, a little bit in South America. But mostly, this is a study that was done in the United States and Japan. And that's important. So that explains a little bit of the body mass index, some of the racial breakdown that you can see here too. Now, at the bottom, really importantly, 70% of people started the study product, placebo or ensitrelivir, by 48 hours after the person who was sick with COVID started to develop symptoms. Importantly as well, ensitrelivir is approved for treatment, as I mentioned, in Japan. So some of the index patients had gotten that drug, about 10%. So that's important to know because they may not be as infectious. And in the United States, it was much lower that anyone had gotten an antiviral, whether molnupiravir or nirmatrelvir. So again, that could change things a little bit, as we pointed out. I will point out in a minute, it didn't really change that much. So bottom line, what did it look like? Well, out of 1,030 people in the ensitrelivir arm versus about 1,011 people in the placebo arm, we can see there were 30 people in the modified intent to treat who developed SARS-CoV-2 household contacts versus 91 of the 1,011 in the placebo arm. It's a risk ratio of 0.33. It's a pretty dramatic difference between 9% of people dropping down to almost 3%, a highly significant p-value. So it worked. here's a nice Kaplan-Meier that tells us not only did it work by day 10, but it started to work early. And that makes sense because you get exposure to the drug really rapidly with that initial loading dose. So it starts to have an antiviral effect pretty early in the course. So the protection can start pretty quickly. And so you can see here the display between placebo and islatravir over time, and it looked really promising and sustained, certainly during the 10 days, and in subsequent secondary analyses, sustained even longer term out to day 28. Another thing we could start doing is looking at some of these data, especially when you have so many people in a clinical trial. You could look at subgroups, and I think that's important because we're always trying to fit, like, do these data fit you, my patient who's sitting in front of me? Like, how apropos is this to you? And so we could look at people who have high risk for severe COVID, and that's a pretty encompassing list. But it's talking about a lot of the things that we're used to talking about. So people who had high risk for severe COVID development, that was present. There was really very similar difference between placebo and the ensitrelivir arm as we saw for the general overall study. So, 9.9% versus 2.4%. And if you didn't have a high risk, ditto. It didn't seem to make a difference. So this worked in people who are at higher risk for severe COVID and people who are at lower risk of severe COVID. And that might be important because some of the lower risk people could benefit perhaps from post-exposure prophylaxis, even if they're not at higher risk for developing the severe illnesses that we think about. And again, remember, like I said before, pretty much everyone is at lower risk than they used to be, with some notable exceptions for people who are on certain medications or have had certain therapeutics that render their immune systems really just unable to mount that kind of immunity we count on with herd immunity. What about adverse events? Always important. Good news here, really not much to talk about. So treatment emergent adverse events, these TEAEs, no difference between the two arms, very similar rates of death, things like that. We know that ensitrelivir from other studies, because this has again been studied as a treatment, and here too, can have some particular adverse events that are a little weird. One is that it can drop HDL cholesterol temporarily while people are on it. It rebounds. Also, hemoglobin could go down by about 2 grams per deciliter. Again, that becomes temporary. Not clear why that happens. That was seen here in the study too, but not clinically significant. So again, those are the data. That is what has led us to understand more about this drug as a post-exposure prophylaxis. I think it's an interesting study, well-designed study, pulled it off. There were some differences by region. Again, most of the study was done in the United States, and there was less of a difference between the treatment arm and the placebo arm in the United States than there was in Japan. And that may have to do with how many people live in a household in the United States versus how many live in a closer setting in Japan. It could also do with variants and what kind of immunity people have developed over time in the United States versus in other countries. So it's unclear. We also saw that the viral load in the noses of people in the United States was lower than what we saw in Japan. But the antiviral activity, which we didn't go over, was evident, all over the world. So this drug has immediate antiviral activity where the amount of virus in your nose, no matter what your starting point is, does drop down. So I think that's a pretty significant finding as well that may help us understand how to use this drug. And again, we mentioned it before, there's no data right now from using, post-exposure prophylaxis for preventing, something like PASC or long COVID. There are other data that, separately that you can look at for this antiviral for preventing long COVID symptoms in the treatment setting. But I do think, again, I think Dr. Wright said it, you can't get long COVID if you don't get COVID. And if this prevents people, on top of whether they're vaccinated or not, on top of whether they wore a mask or not, or whatever, if this could prevent people from getting COVID, then I think this is a really effective way to prevent long COVID.
That was excellent. Thank you so much. So now what we're going to do is we're going to turn back to Dr. Vega and take this information and translate this evidence into practice. So I'm hoping you'll lead us through and we'll have some conversations about this as we move to wrap up this program.
Yeah, we only have a few minutes, so maybe like a rapid fire kind of. I've got a few cases for you, and I just want to know: would you recommend ensitrelivir for these patients as household contacts of somebody who is sick, presumably with COVID-19? And the first case, I think, is fairly straightforward. 68-year-old with diabetes and heart failure, preserved ejection fraction. Would you be a yes on that or not so sure? You see me thumbs up, thumbs down. Thumbs up,
Thumbs up. Thumbs
David?
up.
Your thumbs up?
Yeah, for sure.
Yeah.
Yeah,
All
I
right.
think for sure. Yeah.
How about a 64-year-old, healthy, walks a mile a day, in great shape, better shape than me? Still thinking because of that age, we have as yes, that is a risk factor. Would you think of a yes? They call you on a Friday afternoon?
I don't think risk is all or none. A 64-year-old is certainly pretty close to 65. There's a lot we don't know about that person, but here's my God. I think that anyone who has gotten exposed to someone who is ill with COVID is a candidate for this medication if it is something that they're interested in. And David, you presented the data, so I don't want to steal your thunder, but I'd love to hear your thoughts on that.
No, there's no theft at all. For me, it's, and I like the way that you giving your more primary care hats that you wear than I do, speak to people and advise them. Whereas I think I'm in a specialty where I do some primary care, but most of it's really for specific things. So taking a tab from your paper, I think I would say, how much do you feel like getting COVID-19 this week? If you want to do everything you can, if you're a belt and suspenders, take an umbrella because it might rain person, this could be a really good idea for you if you fit the clinical trial. And I think the good thing about the clinical trial, as I said, it involved people 12 years of age or older living in a household. It was pretty broad inclusion criteria. So for me, it's almost going to be all the above. That's not a rapid fire answer. But for me, I just feel like, it's a safe drug. And this is something I think, Dr. Wright, you said that it's not a hard decision whether or not to get vaccinated. It really shouldn't be. It's been made hard. Um, by forces that we don't control very well. It shouldn't be a hard decision. The vaccines are very safe. It's not going to make you ill. It's not going to cause bad things to happen to you. So again, this is a drug that's well tolerated, safe. And again, it could come out to a cost or something like that, which is very legit. But when we talk about risk benefit, and that's where I take issue with the CDC, and Chuck, you showed the slide, the risk benefit, well, when the risk is really, really low, all you're left with is benefit.
No, you're absolutely right. And all of the above is the ultimate rapid fire answer because you're saying yes to everything. So that's a big swipe right and we're done.
I want to give it to the worried well. If someone says, I don't know that I'm exposed, but I'm just maybe, I was on a subway, and I think we talked about that offline. I agree. That's exploiting the drug, right?
But that's really rare. And I think, again, go back to the fact that we know that post exposure prophylaxis is widely underused. And so, and I was thinking the same thing to thinking about vaccines and the risk benefit ratio. We had the incredible efficacy of the vaccine in preventing infection, over 95% with those first studies that came out. And then it just dropped and dropped as resistance grew. And that's just how it goes. I mean, we have a very clever virus that's undergone a lot of modulation and mutations over time. So therefore, what is the risk of the vaccine? It's very low. So even if you get 55% reduction in the chance of getting COVID, as you said, do you want to? Why would you want to get COVID and put yourself at risk, especially as you have more risk factors, as is so common? I think of encefalitis as the exact same way. That we have as something that's really well tolerated. I think very importantly for our audience, it's not like taking an antibiotic. We're not so much worried about viral resistance increasing, especially with the fact that it probably won't be used as broadly as we do use drugs like amoxicillin, et cetera, all your antibiotics. So therefore, I think it does have a role, and it should be something with shared decision making. Just make sure that somebody got a COVID test that we know that person at home. I feel better knowing, even if it was a home antigen test that's positive, that's what we're dealing with is we have somebody who's exposed to COVID-19 specifically.
I think the study was pretty clear in that not everyone that was in that study was at high risk. In fact, many of them were considered to be low risk for bad outcomes from COVID. So for me, that just tells me it is an option. but I don't think a lot of people are going to know about it. And this is one of the great things I think we have as educators in this program is probably a lot of our colleagues who are watching today have not heard about this medicine and have not heard that it was just FDA approved. And we have the ability to initiate these conversations, which brings me to the next pearl, if you will. If either one of you have a little pearl, and we can sum this up really quickly, how do you approach PEP decisions?
I have a standard line. So when I get that vaccine on board, and by the way, after you've gotten the vaccine, it doesn't always work. So if you are exposed to COVID-19 and you have a test, so please test. And if you are exposed, call us right away. We can prescribe you Incitravir. So that's a nice thing to plant as a seed in the fall before you get the winter spike.
Think that's great. And then I'd ask one other, what are some strategies to communicate with the care team? So again, these meds are good, but you have to know about them as a provider to be able to recommend them for the patients that we see. What are some things that we can do beyond a program like this to communicate to our team?
Yeah, I think that these programs, which I think are really important because you get, unfiltered, perspectives and presentation of the data are important. And I think, this was just published in the New England Journal as well, so it's out there for public consumption. But I do think we're going to have to deputize others. I think we're going to have to speak more about this. The other thing, though, that I think we have to really not fail to mention is that this isn't for everyone. And the number one thing that will limit its use is drug-drug interactions. And so, like, maltravir, this does have sort of a similar profile given its impact on the cytochrome P450 system and the metabolism of other drugs. So I don't want to not pay attention to that. I think that's important. The other thing that comes up, I think, in some questioning, and again, when we talk about primary care people, is what do you do if somebody does develop COVID-19 after taking PEP? And then really, I think the options are probably to switch to something for which there's, more data and approval for in the United States, um, like nirmatrelvir. So again, those are some things that people might ask us. But your question's a good one, and I think we should just do what we're doing now. And I like what Dr. Vega said about like at the time that you're prescribing me or recommending a vaccine, you could say, and by the way, whether they say yes or no, just know if you do get exposed to COVID-19 or the flu, we have something for that. And so just call me as soon as you can and we can get that to you.
Awesome. I think the CYP450 or the 3A4 isoenzyme is such an important conversation because we know that's a limiting step for some of the products that are already available for treatment. And so people who are prescribing this need to know what other drugs patients are taking. One of the things we do before we prescribe nirmatrelvir ritonavir combo is we say to patients, we need either a telehealth visit with you or we need to see you in person because I need to walk through every drug you're putting in your mouth before I can add something on that is a strong inhibitor of the 3A4 isoenzyme. So I think it's important that we recognize that this drug does use the 3A4 pathway for its metabolism. And I'm now going to wrap us up and ask if any concluding remarks or any takeaways that any of you want to just leave our audience with at this point? Or do you think we've covered it?
Well, I think whenever you need inspiration, just think of, we all know somebody who was really hurt by COVID-19, both in our practice and then in our personal lives. So we really want to think about, protecting it, folks, as much as we can and maximizing that while respecting where they're coming from and their value system.
I agree.
Yeah, and I don't have much to add. I think that, again, as we started, anywhere, depending upon the season, between 1 and 1,000 or 1 and 100 of people who die in the United States right now are dying from COVID-19, depending upon the season. So it's not gone. It's not as deadly, not as existential as a threat as it was before, but it's not gone. And not only that, it makes a lot of people really sick, including long COVID, but even just being sick, which is not great. So we have something that's safe and well tolerated that we can give to people who don't have interactions with other medicines that could make them feel better, that they're not going to get COVID-19. I think why not offer it? At least let them know about it. So I feel this is another one of these steps in trying to get us as far away from this pandemic as possible. And I think it's an important one.
And I would just say to all of our colleagues, don't give up the fight. It's a hard time, but none of us ever shy away from things that are hard. And so continue to have the conversations, continue to make your recommendations known, and do it in a strong, presumptive manner that you're comfortable with. But just remember that you do have the power to move that pendulum. And with that said, everyone, Chuck, David, I want to thank you both. It was a great discussion. And for all of you who are participating in this activity, thank you. We want you to continue to answer the questions and make sure to complete your evaluations so that you can claim your credit for participation in this program. Again, thank you so much. Until next time, everyone.